Good morning to everybody. I'm Dr. Naidu. I'm one of the physicians based at East Rand Physicians in Benoni at Life the Glenwood Hospital. And I'm going to be talking to you today about diabetes mellitus and heart failure. So the talk is entitled The Perils of the Sweet Heart. This is just a disclaimer, just to state that the facts and opinions expressed in this presentation are those of my own and do not necessarily reflect the opinions or position of the sponsor, AstraZeneca. Just a few disclosures to say that I'm also a speaker for Servier, Novartis, and Boehringer Ingelheim. What should I know about diabetes and heart failure? We know that heart failure poses a significant global burden of disease. There's a heart failure. In 2016, heart failure was the underlying cause in almost 80,000 deaths in the US. Approximately 50% of patients diagnosed with heart failure will die within 5 years of diagnosis. Diabetes affects the pump, which can result in heart failure. It can affect the pipes, so your coronary arteries, which result in major adverse cardiovascular events, defined as non-fatal stroke, non-fatal myocardial infarction, and cardiovascular death. Diabetes can also affect the filter, resulting in renal disease or diabetic nephropathy. Rates of all-cause death and cardiovascular mortality are declining, but remain increased in type 2 diabetes. As we can see in the red line, these are patients with diabetes, and they both increased in patients with diabetes for all-cause mortality and death from cardiovascular disease. Heart failure and diabetes, it's one of the most common cardiovascular complications of diabetes. It's the most disabling and deadly complication of diabetes. There are very high rates of subclinical heart failure and diastolic dysfunction in diabetes. So these types of patients may complain of exertional dyspnea or shortness of breath or becoming tired while climbing 2 flights of steps. And we also know that there's different effects of the glucose lowering agents on heart failure. So just to look at the pathophysiology of cardiovascular disease and diabetes. It's complicated and there are a lot of role players. So there's oxidative stress, inflammation, insulin resistance, and vasculopenia, which can result in atherosclerotic events, which leads to cardiovascular death. Similarly, there are heart failure events which can develop, which also lead to cardiovascular death. And then there's the interplay of kidney disease with both cardiac disease and the atherosclerotic events, which leads to cardiovascular death. So these patients who develop the cardiorenal syndrome are extremely difficult to treat in the sense that it's difficult to play with their fluid status in terms of diuresis and overdiuresing. Is the cause of cardiovascular related hospitalizations amongst people with diabetes. As we can see, it's more common than patients with ischemic stroke, cardiac dysrhythmia, and acute coronary syndrome. Heart failure also represents the most unfavorable prognosis in type 2 diabetics. As indicated in the graph below from Zerini B. et al., we can see that heart failure increases the 5-year absolute risk of death, more so than ischemic heart disease, chronic kidney disease, stroke, and peripheral arterial disease. This is a slide from the Swedish National Diabetes Register, who looked at what type of risk persists despite adequate control of 5 risk factors. So they looked at HbA1c reduction, LDL reduction, urine albumin creatinine ratio, smoking status, and blood pressure. As we can see, there hasn't really been a significant increase in excess acute myocardial infarction or excess cases of stroke. However, in patients with heart failure, the risk persists despite risk factor control. And concerning is the fact that in our younger age group, the less than 55 years, it significantly increased with a hazard ratio of 2.4. Diabetes can result both in heart failure with preserved ejection fraction. So these patients have a left ventricular ejection fraction more than 50%. The left ventricle is hypertrophied and it's concentric, so it's thicker and stiffer, and they result more in diastolic dysfunction. whereas patients with heart failure with reduced ejection fraction typically have a left ventricular ejection fraction less than 40%. They have an eccentric dilatation, and they have a systolic dysfunction, so difficulty in getting blood out. And both of these can result in cardiovascular death and hospitalization due to heart failure. We can then look at heart failure staging, so according to structural aspects and according to clinical aspects. So the American Heart Association stages of heart failure looks at the structural aspect, with stage A being patients at high risk for heart failure but without structural heart disease or symptoms of heart failure. B are those patients with structural heart disease but without signs or symptoms of heart failure. C are those patients with structural heart disease with prior or current heart failure. And D are refractory heart failure requiring specialized interventions. In comparison, the New York Heart Association classification is more of a clinical scale, with class 1 and class 2 patients being asymptomatic, class 3 patients being symptomatic with mild exertion, and class 4 are those patients who are short of breath even at rest, and these patients typically have refractory end-stage heart failure. And diabetes remains a risk factor at all of these stages. We also know that heart failure is more common than myocardial infarction and stroke in insulin-treated people with type 2 diabetes. And diabetes has been included as one of the top 3 predictors of mortality in a few adverse heart failure prognostic scores. Type 2 diabetes increases rehospitalization for heart failure. There's more all-cause rehospitalizations. It's a predictor of readmission for heart failure. It's independently associated with rehospitalization for heart failure. And patients with type 2 diabetes typically have longer hospitalizations because of the more complicated clinical course. Heart failure hospitalization is a key driver of the disease burden. It's one of the leading causes of hospitalizations and the #1 cause of hospitalizations in patients more than 65 years old. And this is based in the US. Readmission rates after hospitalization for heart failure are as high as 30% within 60 to 90 days. And approximately 30% of patients die within the first year of hospitalization for heart failure. So a few other features of diabetes and heart failure. They typically have worse symptom control and functional status, worse renal function, more autonomic dysfunction, more pulmonary hypertension, impaired arterial vasodilatation, greater LV diastolic dysfunction, and abnormal myocardial metabolism. The cardiorenal outcomes, including heart failure, increase with declining renal function. So if we look at what happens as the kidney function declines, there's an increase in renal events, increased MACE, increased hospitalization for heart failure, and all-cause death. So this is a brief overview of key cardiorenal interactions in diabetes. We'll start off at the top with hemodynamic mechanisms, essentially fluid overload and retention of salt in water. Renal and cardiac congestion then follow with renal venous hypertension. There's limited organ perfusion resulting from forward failure and vasoconstriction in end organs. Neurohormonal mechanisms also exist, so it results in the activation of the renin-angiotensin-aldosterone system, which results in the retention of sodium in water and also vasoconstriction of some of the afferent arterioles. And it also results in activation of the sympathetic nervous system. Cardiovascular disease-associated mechanisms include chronic inflammation and activation of cellular immunity, malnutrition, cachexia and wasting, bone mineral disorder, acid-base metabolism disorder, and anemia and cardiorenal anemia. So there's a vicious cardiorenal connection that exists in heart failure, both on the arterial side and on the venous side. Starting off with the arterial side, there's arterial underfilling, resulting in decreased cardiac output, decreased effective circulating volume, decreased renal blood flow and renal plasma flow, and activation of the RAS and sympathetic systems. The venous congestion can result in venous hypertension and increased intra-abdominal pressure, decreased AV perfusion gradient, resulting in kidney interstitial edema, and again, activation of the RAS and sympathetic nervous systems. So in summary, diabetes is a very important and underappreciated risk factor for the development and clinical course of heart failure. There's multiple direct and indirect mechanisms that have been suggested to cause heart failure in diabetes, irrespective of the phenotype. The presence of renal disease is associated with worse outcomes of heart failure in diabetes, so the cardiorenal spectrum. And heart failure is strongly associated with insulin resistance and dysglycemia. Prevention and treatment of heart failure must be a priority in people with type 2 diabetes. So let's go on to look at the data supporting the use of SGLT2 inhibitors for the prevention of heart failure and diabetes. As we know from the UK PDS study, there is an association of A1C or HbA1c with cardiovascular risk in type 2 diabetes. There's almost a 14% increase per 1% increase in HbA1c of fatal and non-fatal myocardial infarction, a 12% increase in fatal and non-fatal stroke. Amputation or death from peripheral vascular disease is increased by about 43% per 1% increase in A1C, and heart failure is also increased by around 16% per 1% increase in your HbA1c. So we can look at some of the evidence supporting other oral hypoglycemic agents. We'll start off with the DPP-4 inhibitors and their cardiovascular outcome trials. As we can see, they all are close to the midline and cross the midline, so pretty much neutral. In terms of hospitalization for heart failure in the DPP-4s, again, remain neutral. The MACE from reported GLP-1 receptor antagonist cardiovascular outcome trials, there does seem to be some evidence. So for instance, in the LEADER trial, there's about a 13% reduction. The Harmony outcomes trial and the REWIND trial all showed beneficial reduction in MACE. If we look at the meta-analysis, we can see that it's to the left of the midline, so around a 12% reduction in MACE. Hospitalization from heart failure, again, most of them seem to cross the midline. And if we look at the meta-analysis, shows around a 9% reduction, but again, most of them are touching the midline. Next, we'll go on to look at the SGLT2s and their cardiovascular outcome trials data. If we look at the EMPEREG outcome trial, which was one of the landmark trials, which ended in 2015, they looked at about 7,000 patients, and they looked at patients who had established atherosclerotic cardiovascular disease, so more of a secondary prevention population. The CANVAS program looked at canagliflozin, and they divided theirs into primary prevention and secondary prevention, with a third of patients having multiple risk factors and 2/3 having established atherosclerotic cardiovascular disease. The DECLARE TIMI trial looked at a higher proportion of patients with multiple risk factors, so primary prevention, and around 40% with secondary prevention. This was quite a large trial. It looked at around 17,000 patients and ended in 2018. So just to recap, secondary prevention, they looked at coronary artery disease, cardiovascular disease, and peripheral arterial disease. Primary prevention were those patients who had risk factors without established cardiovascular disease. DECLARE TIMI has the largest proportion and numbers of type 2 diabetes patients at a low cardiovascular risk among the SGLT2 inhibitor cardiovascular outcome studies to date. This is important because we need to know how beneficial are the SGLT2s for primary prevention. Less than 15% of the SGLT2 inhibitor cardiovascular outcome trial study cohorts had a history of prevalent heart failure. And just to look at a few of the key outcomes. In the EMPEREG outcomes, MACE was reduced by 14%, relative risk reduction. Hospitalization for heart failure was reduced by 35%. Composite outcome of cardiovascular death and hospitalization for heart failure was reduced by 34%, and renal outcomes by 39%. CANVAS program was pretty similar. MACE was reduced by 14%, hospitalization for heart failure by 33%, composite cardiovascular death and hospitalization for heart failure reduced by 22%, and renal outcome by 40%. The declared TIMI had less of a reduction in MACE, and this is presumably because of the fact that their population had more patients of primary prevention. However, hospitalization for heart failure and the renal outcomes were still significantly reduced. We look at the Credence trial, which was essentially a renal efficacy study. So type 2 diabetics with albuminuric chronic kidney disease. The primary outcome was reduced by 30%. Hospitalization for heart failure was reduced by 39%. MACE was reduced by 20%. So this graph just depicts the net benefits of the SGLT2 inhibitors according to their risk of cardiovascular death and heart failure hospitalization. So we know that there's an established cardiovascular benefit of SGLT2s, and this was shown in our Canvas trials and our declared TIMI trials. So diabetes with cardiovascular risk factors, our primary population or primary prevention population. Established atherosclerotic cardiovascular disease was also significantly reduced. The renal efficacy trial also showed benefit. And more recently, we looked at patients with and without diabetes with established heart failure. So the DAPA-HF, the Emperor Preserved and Emperor Reduced, were released within the last year or two and showed significant benefit in terms of mortality and morbidity. So let's look at MACE reduction across the SGLT2 cardiovascular outcome trials. As we expect, EMPEREG outcome in the Canvas program showed significant benefit. Declared TIMI was around 7%. So it's clear that the SGLT2 inhibitors prevent hospitalization for heart failure in a broad group of patients of type 2 diabetes, and that they reduce MACE only in our high-risk patients with atherosclerotic cardiovascular disease. So if we look on the left, so hospitalization for heart failure, there's clear benefit in patients with established atherosclerotic cardiovascular disease, with around 29% reduction, and patients with multiple risk factors were reduced by around 36%. When we're looking at MACE, definite benefits in patients with established atherosclerotic cardiovascular disease, so that's around 14%. Multiple risk factors wasn't as significant. When looking at the composite outcomes of cardiovascular death and hospitalization for heart failure, according to the presence or absence of atherosclerotic cardiovascular disease, we can see there's significant benefit in both groups. Looking at the composite outcomes according to the presence or absence of heart failure history, again, significant benefit in patients with and without heart failure. We also know that there's a delayed decline in renal function across the SGLT2s in both patients with atherosclerotic cardiovascular disease and multiple risk factors. So quite similar, that's a 44% and a 46% reduction in relative risk. The cardiovascular death rates across the SGLT2s, it was decreased more in patients with established atherosclerotic cardiovascular disease than those with multiple risk factors. So this is a graph depicting dapagliflozin's cardiorenal benefits, and just to show that it has the greatest benefit in reduction of MACE in patients who have had a myocardial infarction in the preceding 2 years. A history of prior myocardial infarction also had a reduction in MACE with a number needed to treat over 4 years of around 39. Patients with multiple risk factors of primary prevention didn't have any significant reduction in MACE. However, hospitalization for heart failure and cardiovascular death and renal benefit was still seen in these groups of patients. The reduction in MACE for dapagliflozin in patients with prior MI is driven by reduction in recurrent myocardial infarction. So out of interest, the decrease in recurrent myocardial infarction is more robust in type 2 myocardial infarctions. So these are related to myocardial oxygen supply demand mismatch, rather than the typical type 1s who have whose pathology is related to plaque rupture and atherothrombosis, suggesting an effect on DAPA on improving the oxygen demands of the heart. So a few key take-home messages on the cardiorenal impact of the SGLT2 inhibitors. They profoundly prevent heart failure and also prevent and treat renal disease and type 2 diabetes. There's several mechanisms, including hemodynamic and metabolic alterations, which may underlie these outcomes. And the benefits, most importantly, are independent of HbA1c lowering and are observed across a broad spectrum of eGFR. So let's look at a few proposed mechanisms. There's quite a few, predominantly natriuresis and osmotic diuresis, so decreased sodium in water. There's reduction in sympathetic nervous system activation, reduction in blood pressure as a result of reduction in water content, improvement in vascular structure and function, increased production of EPO, reduction in glucotoxicity, increase in vascular regenerative cardiac stem cells, improvement in cardiac microvascular function, modulation of cardiac energy metabolism, reduction in uric acid levels, and a reduction in the myocardial oxygen supply demand mismatch. So the question is, do the SGLT2s cover it all? So in terms of MACE reduction, definitely in patients with established atherosclerotic cardiovascular disease. And in terms of primary prevention, they definitely help to prevent heart failure and renal disease. However, there's no evidence of reduction in MACE in these patients. So let's go on to look at the latest treatment algorithm according to the Heart Failure Society of South Africa with regards to chronic heart failure. So if we have a patient who we think has heart failure based on a good history and examination, we then go on to do additional testing. This can be done by ECG, chest X-ray, or drawing NT-proBNP levels. If there are any abnormalities, we should go on to imaging by echocardiography. If the left ventricular ejection fraction is less than 40%, our patient has heart failure with reduced ejection fraction. We then need to assess the etiology, precipitating factors, and their functional class. We then go on to treat our patients, and the choice of therapy, they've divided quite nicely according to therapy that reduces symptoms, hospitalization, and mortality. So I'm going to focus more on the mortality reducing drugs. So the angiotensin receptor blocker and neprilysin inhibitors have recently been reduced and become available. We know that there's good evidence, as indicated in the Paradigm HF trial, that it reduces mortality in HF-ref. ACE inhibitors and angiotensin receptor blockers, cardioselective beta blockers, mineralocorticoid receptor antagonists have all been around for years and have been the mainstay of treatment for HF-ref for years. And importantly, they've now added the SGLT2 inhibitor to this group of drugs. This is the latest ADA 2021 standards of care for anti-hypoglycemic medication in type 2 diabetics. The first-line therapy remains metformin and comprehensive lifestyle changes, so diet and lifestyle. We'll then go on to look at indicators of high risk or established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure. And these are then considered independently of baseline A1C, individualized A1C targets, or metformin use. If our patient has established atherosclerotic cardiovascular disease or high risk of atherosclerotic cardiovascular disease, such as age more than 55, with coronary, carotid, or lower extremity artery stenosis, more than 50%, or left ventricular hypertrophy, the evidence in the guidelines say to use either a GLP-1 receptor antagonist or an SGLT2 inhibitor. If our patient has heart failure, particularly HF-ref, and now more recently even HF-pef, as per the Emperor Preserved, an SGLT2 would be the drug of choice. If there's established diabetic kidney disease and albuminuria, preferably an SGLT2 should be used, or if for whatever reason we can't, then a GLP-1 receptor antagonist. So where do we place SGLT2s in the treatment of type 2 diabetes and patients with atherosclerotic cardiovascular disease and high-risk indicators? Well, it's definitely a drug that should be used, regardless of baseline A1C, individualized target, or metformin use, because of the benefit in MACE reduction and hospitalization for heart failure. We should also take note that the SGLT2s are recommended for use to reduce the risk of heart failure hospitalization, and this is a class effect. So either dapagliflozin, empagliflozin, or canagliflozin, although cana is not available for use in South Africa. If we look at patients who we need to minimize hypoglycemia, again, choice of drugs include the SGLT2 inhibitor, GLP-1 receptor agonist, TZDs and DPP-4 inhibitors. If we need to promote weight loss or minimize weight gain, drugs of choice include the SGLT2 inhibitor and the GLP-1 receptor agonist. We know the GLP-1 receptor agonists probably have a better effect in terms of weight loss, and some of these drugs are soon to be included as weight loss drugs, such as semaglutide. If there are cost issues, sulfonylureas or TZDs can be used. And this is just a summary of the European Association of Diabetes guidelines, which is quite similar to the ADA guidelines. So let's move on to our case scenario. This is Mrs. AM, who's a 45-year-old female patient. She's hypertensive and diabetic. She has had recent weight gain and reports some exertional dyspnea. She is on a combination tablet consisting of Coversil, amlodipine, and indapamide. She's on metformin and gliclazide for her diabetes. Blood pressure is borderline at 140/90, so above target for a diabetic. BMI is 33. HbA1c is 8.1. Cholesterol is elevated at 5.3. She has a urine albumin creatinine ratio of 120 and an eGFR of 88. So what happens if she continues to gain weight? So say her BMI goes to more than 35. What drugs do we have available? Well, as per the guidelines and the evidence, we can see that the SGLT2s and the GLP-1 receptor antagonists would be the drugs of choice. If cost is a factor, the SGLT2s are probably more cost effective when compared to the GLP-1s. And also just to remember that the GLP-1s are injectables, so the patient needs to be comfortable giving themselves an injection. What happens if our patient shows a further decline in renal function? Again, as per guidelines and evidence, we want that patient on an SGLT2 inhibitor. If our patient develops worsening blood pressure control, well, definitely we should try and get the patient onto maximum doses of the combination tablet. From a diabetic drug point of view, we can look at adding an SGLT2, which has a modest reduction in systolic blood pressure of around maybe 3 to 4 millimeters of mercury. If the patient loses glucose control and the HbA1c goes to 8.9, what can we do? Again, different types of drugs, an SGLT2, a GLP-1, or a DPP-4 inhibitor can be added, or even all three. Well, you can't really use the GLP-1 and the DPP-4 together, so either the SGLT2 with a GLP-1 or a DPP-4 inhibitor. So what happens if the cardiac echo shows a left ventricular ejection fraction less than 45 and a raised proBNP? Well, we should then look at putting the patient onto an SGLT2 as per guidelines and as per evidence-based medicine. If our patient is on an SGLT2 and they start to develop mild genital infections, what should we do? Well, we should try and treat the patient for their mild genital infections, so either with oral medication or topical medication, and also just reinforce good hygiene. So when should I consider an SGLT2 inhibitor? Remember that SGLT2 inhibitors were developed for treatment of diabetes. They have a reduction of around 0.5 to 0.8% reduction in HbA1c. They help with weight loss. They're beneficial in patients with renal dysfunction. Empagliflozin can be used with an eGFR up to 30 moles per minute. Dapagliflozin, currently 45 moles per minute in type 2 diabetics and 30 moles per minute in patients with HFrEF. It's very beneficial for patients in HFrEF. And just remember that a majority of the patients in the trials were already on optimal medical therapy, e.g., or for example, the beta blocker and the ACE inhibitor or ARB. The SGLT2 should not be used in type 1 diabetes because it increases the risk of euglycemic DKA. And just remember that it can also increase the risk for urogenital mycotic infections. So diabetes mellitus and heart failure. Diabetes mellitus is a multisystemic disease, and is a significant risk factor for cardiac disease, especially heart failure. Good glycemic control has been shown to decrease adverse events across the board, cardiac, renal, and other. SGLT2 inhibitors have shown favorable outcomes in diabetic patients with heart failure, as we have seen in the cardiovascular safety trials discussed earlier. And these cardiovascular outcome trials have laid the foundation for further trials involving SGLT2 inhibitors in cardiac failure. Thank you for your attention, and to AstraZeneca for arranging this talk. Are there any questions or comments?